On behalf of NHS, welcome to COVID-19 Cost and Challenges for Health Systems and Payers. You may have heard there's a pandemic going on. My name is Marla, for those of you who had not joined the previous sessions. At this time, I'd like to introduce Vanita Pindolia from Henry Ford Health Systems, who will talk to you about the COVID-19. And with that, take it away, Vanita.
Great. Thank you, Marla, and welcome to this new venue of doing our meetings here. We're going to review the healthcare system's response to the pandemic from the spring to now, what's going on, identify costs and challenges related to managing the COVID-19, and then really drill into really the impact at the HTCs from there. So I just wanted to kind of level set, where are we now with the whole COVID-19 stats and where we think, what could happen because of those stats. So this slide is to really show just in the last 2 weeks, what was the change in confirmed COVID-19 cases. So you can see the darker, the reddish color, the more increase over the last 2 weeks. So if, let's say, a country has had very high counts and then the next 2 weeks has remained very high, it stays kind of more looking blue. So it's misleading. It's not to say they don't have high COVID, it's just they didn't change. So for the US, you can see here the number of cases. We did see an increase, and we continue to see this probably since late August, early September. But and the number of deaths are also rising, not as much as the cases, but that's really the bigger concern there. So what about looking at our confirmed cases cumulatively? So here, this is the US, and you can see it's just been steadily going up. And this very much is due to the increase in testing capabilities. So it's not necessarily a negative thing. The part that's concerning, though, the more confirmed cases you have, the more isolation, the more we should be doing to understand who they were with and to kind of contain it so that we don't get to the increased deaths. The reason I called out these countries specifically here is for us to understand what were their cumulative confirmed COVID cases per million people, so you can get it equalized there, normalized for population size. And New Zealand and Australia, to me, are really the key to see. You can see this huge flattening in New Zealand, and they basically shut out their country. Nobody can travel in and out for the full 8 or 12 weeks, and that's really how they prevented entry and spread, and it's like a normal country. They do everything open. Likewise, Australia, they got that blip, and then they leveled. You can see United Kingdom and France had an actual pretty steep increase here, and the US is steadily increasing. These are the two countries that we don't want to look like, because when that happens, we also saw their per million death rate. So France and UK, you see this huge increase end of August to now, whereas Australia and New Zealand is flat. The reason I'm sharing all this is, there's been all this talk about, is there going to be another second closure and what would happen? And this is the part we're really monitoring very closely, right, in the US. So we're at least staying steady, but we're been continuously having a little bit more every day since the fall. If we see a steep increase, we'd have to go back into tighter restrictions. And here in the US, it differs state by state, which is also making it more difficult to contain. So what kind of an impact did the COVID-19 pandemic have on employment? So looking at payment and ability to even have insurance or go see a doctor and pay your co-pays, etc., get your drugs. So you can see from the March of when everything kicked off, you see this huge amount of, the unemployment rate. And then that's slowly coming down as, more and more states are opening up. There isn't as tight closures. And then you can see, though, the impact on small businesses was most devastating, where they might have started with temporary closures, but many of those converted right away into permanent closures. They just could not sustain that level of closure for many months. So this, obviously, what this is causing is then more people going to Medicaid and dependent upon the state for their insurance at that point. Also, there was assistance being given financially during COVID. Many individuals who had a low starting salary, hourly salary, were actually given more by their state that it didn't make sense for them to go back to work. And which is why you hear like McDonald's or chain stores and franchises are struggling because the high school level education employees and the amount they were paying, the state's paying more and they're not coming back. So they don't even have enough employees to service their customers. So now that we understand kind of the level where we are with the pandemic and what we're facing, and I think the concerns, I think the biggest one is that in November of many universities are going to send their students back to live with their parents. And the bigger concern there is I think everyone knows we are seeing a pretty big surge across the US and in the university settings, specifically in Greek life in the dorms, where they're having a higher positive rate. This is a younger population. They don't seem to be getting as sick, so we're definitely not seeing an increase in our ICU bed stays or maybe some hospitalization, definitely not as much for the younger. But when that young population goes home to see their parents who are in their 40s or 50s or grandparents, 70s, that's where that risk for mortality, hospitalization, and everything could go up. So most universities are saying it's going to be classes virtual after Thanksgiving to the end of the semester. So there's going to be a surge of all these students moving home. So that's, I think, an area that we're all interested to kind of see, like, let's make sure things don't increase for cases. So really the goal for the healthcare system is we want to try to maintain the capacity. Most health systems, what they couldn't handle in March, April, and May was this, where we had this huge surge of needing all that bed care, all the healthcare resources all at once. If that same population was spread over many months, we could have managed that. And that's what we don't want to see again. There's also impact on the communities. We saw, again, we talked about employment and the expenses, ability to pay the bills, physical environment and having housing, food stability. That became a big concern for many of our members. We actually, at Health Alliance Plan here in Detroit, Michigan, we ended up launching, I think there's almost 8,000 patients that we called to see if they were just okay, were they in, and if they needed food or what was going on, and tapping into resources for that. Social integration. Many of our patients do have a underlying depression. Many patients with chronic diseases, I should say, have that as also, and having social isolation was not a healthy thing for many of them. So that also went right into this healthcare system area of mental health. There's also a big impact on physician offices that I know many of you are well aware of. Looking outside of HTCs, but let's just say primary care, many private physician offices had to close shop during that March, April, May period. They just were not ready for virtual care and that they weren't equipped to do this. Patients with chronic diseases such as diabetes didn't come in to have sugars checked, didn't have their blood pressure checked. We're falling behind on our HEDIS metrics nationally as well for quality. Patients are reluctant to come into the office. They're scared. They're not sure. Outpatient elective surgeries just kind of went away. They were gone for many months, which is a huge source of income for most of our hospitals and health systems. Even if they were outpatient, most hospitals have a connection with that outpatient facility. Patients were cautious of going to outpatient laboratories. Again, just wanting to decrease any exposure, and preventive vaccines, our rates have just plummeted quite a bit. Fewer patient claims translates into significant loss of income for the physician offices. So the health insurers are collaborating with many of their providers to try to see what we can do to make sure there's provider adequacy so patients can go see a doctor if they need to. So what is managed care, or what are the payers doing to support? There's been a huge expansion in telehealth medicine, and we'll be talking about that a little bit more later. Removed all prior authorizations for COVID-19 testing, allowing refill medications earlier so that we don't have to just wait till something runs out. Waiving member cost share for COVID screening, testing, related treatments. No prior auths needed for the diagnostic tests and covered services deemed medically necessary using CDC guidelines. Lots of free in-home medication delivery services being offered. And many states authorize pharmacists to go ahead and do an extra refill even if the prescription had become void, just so that if they weren't able to see their doctor, they needed their blood pressure med, that wasn't the reason that they weren't getting it. It's also had a lot of impact on the members' attitude towards care. Now, this is from May 21st, 2020, so this isn't updated, but I think a lot of what we're seeing, we're starting to see a little bit more opening, but back then, at least, reluctance to access service during pandemic, nearly 45% for that. 72% indicate pandemic has impacted their health care. 41% of seniors delaying care, 60% chronic conditions. We know this because we can see the negative impact on our HEDIS scores. 28% of seniors increased the use of telehealth. I mean, we saw a huge surge. And the smartphone apps increased popularity as well. Here, there's a stat, 81% expect fall-winter COVID resurgence. So it's interesting for May, and we still have that continuous concern. So it's in existence. Continuing to see how it's impacted members' lives. The pandemic has had 24% of our members' financial status, and we've talked about food and housing, but that's really become significant as the furloughs really increased quite a bit. At least 21% of members worried about losing health care in the next 6 months because they're not sure if they will be called back to work from the furlough. 58% view their doctor as the most trusted source of COVID information, which is really good, but it's kind of sad that there's almost another 40% that are looking at other sources to tell them what to do during COVID time. Members see health plan as another trusted information source, so that's another positive. I thought these graphs were kind of telling to see, during the initial pandemic, what happened to MI rates. And we had a plummeting, like all of a sudden people weren't having heart attacks, and also our stroke rates. But really what happened as things started opening up, unfortunately, people going into homes to see neighbors who were lonely or alone found that they did have a heart attack or had a stroke, but were just stayed at home. We had patients that we were calling for our medication therapy management, and times that they were like, I can't breathe, but I don't want to go to the ER. And it's like, but you have to. And they were that afraid. So it's kind of sad that this doesn't mean we all of a sudden saw a decline in heart attacks and stroke because of COVID, but it's just people weren't going in and many died in the homes. We also saw a decline in our screenings. Our breast cancer screening, colorectal, cervical, all have plummeted. And I can tell you right now, with all the effort we're doing here in Detroit, Michigan, providing incentives to providers, incentives to members to just go and get that screening done, because we are so far behind because during closure, people weren't ready to. And now that things are opening up, it's preventive. Do I really need to? And really getting that education of the importance of it. So all of those things together has had a financial impact on our healthcare system. We have seen an increase in medication use, so there was an increase in medication spend, as well as in nursing homes, but a decline in hospital use. When the COVID cases were coming, everything was geared for, the hospital was all about COVID ready, right? And like I said, I just showed you what happened to our MI and our stroke rates and how they decreased like that. The physicians, dental, I mean, they were just closed. It's interesting, when they opened here, at least in Michigan in June, they are just stacked up with appointments. So there are so many patients that are wanting to have that dental visit. So at least the dental screening seems like that's working. Home health care obviously went away, which was so needed for many of our patients. PT, occupational therapy, all of that. So on the slide, what I went ahead and said here, what were our spring, in spring 2020, what did we find were the biggest concerns with the COVID pandemic? And then now as we go through and approach winter 2020, 2021, have those concerns been addressed? So hospitals explained that they were unable to keep up with testing demands because they lacked the complete kits. I think that's been pretty much remedied now. Hospitals described extended waits for COVID testing. We do have more rapid results now. So it's not to say they're 100% accurate. There still is the false positive and false negative even as well. The specificity and the sensitivity aren't 100%. The testing challenges exacerbated others, such as having bed availability or PP supplies. I put a check. I'm just not sure about the staffing shortage, depending on what kind of surge we would get. Hospitals reported that heavier than normal use of PPE contributed to shortages. I think every major health system has gone ahead and made sure there's an abundant supply of PPEs as we approach the winter. These next two, though, I'm not quite sure. if it's quite there to say that we have addressed it. Hospitals report a shortage of specialized providers needed to meet the anticipated patient surge. Before in the spring, many of our providers, physicians, nurses, all these healthcare providers were getting COVID, and they themselves were then being removed, obviously, from the workforce. So we had a big challenge for workforce. And then the hospitals reported unable to discharge patients to certain post-acute facilities while awaiting COVID-19 testing. And I would say even after that, many of our patients, if they were, they got COVID-19, they're being treated, and now we're ready to discharge them. We had a difficulty finding SNFs, skilled nursing facilities, that were willing to accept patients who were COVID-19 positive. So then they would just stay in a hospital bed and further expose themselves to other infections. So it really snowballed on that one. And I don't know if we're ready to say that's been fixed. So how might hospitals respond, maintaining financial viability? So we want to continue providing needed care and retain the staff. Hospitals report assessing their ways to manage their cash flow in different ways, different supply chain, implementing mandatory voluntary time off for staff that are not busy or essential. We did a lot of rearrangement of staffing at Henry Ford Health System, have our own optical stores, Optimize, and they all shut down during the COVID pandemic during March, April, May here in Michigan. And a lot of those staff were put all of a sudden into a hospital setting and having to do temperature checking and checking people in, and jobs that normally are not part of their function in any sort of way. If that job was done, but yet their store or facility didn't open, then we'd have to do mandatory time off or mandatory vacations. Identifying grants and other funding opportunities, flexibility and staffing, pay cuts, furloughs, layoffs, and that's, I think, impacted every health system. Reducing any other inventory that's not related to COVID-19, at least during the prime pandemic effect. How about the health plan? How did it navigate? So plan member testing versus community testing. So we were trying to see if churches or other places could try to help support this as well. Pandemic surveillance and tracing, it's something, pop health type of function that a health plan can do. Shifting of roles when utilization management is no longer a prime function. So many of our staff, nurses or pharmacists that were doing many utilization management of whether prior auths, et cetera, we really weren't having as many coming in because there weren't many patients going to doctors. So shifting those to other functions, such as, like I said, we did 8,000 patient outreaches to just say, are you okay? Do you have food supply? Are you having challenges with rides? Do you need access to healthcare? Can I set you up with telehealth? Things like that. Supporting members' needs when clinical care are unavailable. We just talked about that. Getting premium dollars where they are needed the most. So transitioning that dollar to maybe incentivizing patients more to go in and see their doctor.
Hey, Vanita, I just wanted, before you move to the next slide, I wanted to raise a question that came up. So with all of the people that aren't typically doing utilization management or PA processes, are you seeing a backlog in turnover of those, or, because you have unexperienced staff that are doing the PAs or utilization management?
So it's actually the other way. We had a decline. I think all health plans, United Health had a huge number that they put out there of submissions of prior auths or of any sort, because people weren't going in to see the doctors for the doctors to do any procedures, as an example. So it wasn't like there was staff that didn't know how to do that function. They just had to go help in other areas of how we can do patient outreach in a different way. In the health system, I think it was where people who were not used to doing a certain function were being put into that function, that role, because we weren't having this huge amount of people coming for chronic disease management, and but we had a lot of people coming in the hospitals and we didn't have enough staff. So it was more untrained staff, was more in the health system side than the health payer side.
Thank you.
So as we had talked about, there was an increase in looking at remote care, and this has really been growing all along, but I think COVID just kind of pushed it to that new level that many healthcare purchasers for sure have been always wanting, And many millennials now have been like, this is how they want to be taken care of just remotely, and trying to help with self-management, basically. Like, why do I have to go in to see what my number is, or why do I have to have somebody tell me it's bad? Like, isn't there a device? And there's many now, whether it's blood pressure, diabetes, those are the big ones right now. But heart failure, having the weight monitoring, etc. And then they get connected through Bluetooth, so the data gets fed back to their physicians or their case managers. And it's allowing that dialogue based on the tool of what gets alerted as a very bad level, whatever that's defined at, so that you can get a call back. There's looking at how the Echo or Alexa or all these tools that are in patients' homes, how that can help provide some feedback to the patient. I think right now with Alexa, there's a lot of HIPAA issues, so they're still trying to go through that of how can a patient be notified through Alexa by their case manager that, hey, I got the alert, or your blood pressure went really high, how's it going? Or I saw that you took 4 inhalations of your beta agonist as your COPD flaring. So things like that. And it's kind of exciting. I think that it would make our job a lot more efficient too, versus trying to call or do things and being able to send messages. So reflecting and rethinking, I guess, of, what does access? We've always thought access is the patient comes in and sees me. I'm the doctor, or I'm in the hospital, so they have to come see me. And it's really been changing over the years, but I think that's been dramatically shifted away through the COVID. So the traditional office visits and the hospital visits really are different channels now, whether it's hospitals at home. There's a lot more of that, having paramedics going in the home and actually giving Lasix right there to our patients, and not waiting for them to have to come into an ER or things like that. Technology-enabled retail medicine, device-assisted acute diagnosis, smartphones, digital coaching. So all these things that we kind of touched on in the last slide. And this slide is very telling to see what happened with telehealth visits. It's been so slow to grow. As much as everybody says this is the way we want to be taken care of, whether it was providers not having the technology or promoting it, whether the payment model wasn't there, again, to promote it, or was it the patients not ready to use that technology? But then lo and behold, come COVID, and we just had a huge surge. So with that, looking at telemedicine, it's a really become a critical component of how to address patient visits, especially in areas that are rural and they can't really get easy access. If there's only 2 doctors' offices to service the area, and they went belly up that they couldn't handle it during this COVID and they still are closed, then where do they go? So we can see here that the strategies for increasing overall visits, the telemedicine visit has increased 60% in hotspot and not hotspot. So which areas of the nation were needing this? And it was looking at 275 payers. And then this was similar, but now looking just for well visits. So how do you do your annual well visit? Can you do that through telehealth? And there's been so much work in the last 6 months of how do we make that a better experience and accurate, and get physicians used to it. That was a big thing. Physicians were not feeling comfortable saying, I took care of my patient properly through a telehealth visit. I think many now are feeling more comfortable with that and feeling like, no, this is good. I am able to take care of the patient, and then address who should come in based on that. So this slide, it's a little busy, but there's 3 phases of the COVID-19 pandemic and demand for telehealth. The light blue is that initial one where we saw the huge surge, and it was the one of, needing stay at home and how do you get your outpatient care. And then phase 2 is the COVID-19 hospital surge that we also saw. So we saw that, and then we saw that slowly come down. But the green one is the one that we're more interested in. This is the post-pandemic recovery, which we still will consider ourselves as long as we don't get a second wave. So patients possibly staying home with symptoms, having serious conditions, but then where is their care? How is it going? And then the surge to do the interventions for chronic and acute care complications. And this is an area that case managers and others, I think, are really learning and growing into. It's not something easy for them to adapt to. They like to touch, feel their patients, and they can't when they have multiple comorbidities, but it's better this than them not getting any care. And then how do we make this not just better than any care, but actually a really good process? So, how health plans can facilitate digital health growth? There's a potential future shift of $250 billion in healthcare visits to become digital care models. It's huge. I engage with multiple healthcare purchasers, employer groups, and this is what they've been wanting for years. And every year, what's our telehealth visit rate? It's 2%, 2.5%. And now this year, to say this high surge of 30%, they're so excited. They're like, I can make sure my staff doesn't have to go offline. We have in Detroit many auto workers. We have many that are on the plant. They can't afford having patient with a sniffles and cold leave in the middle of a line in a day to go see a doctor. But if they can go have a break and do a telehealth visit, their lines don't go down, as an example. COVID-19 has dramatically changed clinician and consumer telehealth opinions. 76% of the surveyed consumers are interested in using telehealth. Providers report a 50 to 175-fold increase in the use. And again, this is the data that was published through end of May. Health plans can accelerate the digital care growth, driving value-driven strategy plan to incorporate the digital health credentialing and contracting to optimize that. Continual building of the digital care. So we have a partnership with Livongo for the diabetes, and it's at no cost to the physician groups, but they're helping to manage their diabetes and send alerts when their sugar levels are going high. And that's really important for HEDIS and all the long-term healthcare costs that go with unmanaged diabetes. So it's a win-win, actually. It's a win for the patient, the provider, and the payer. So that's where digital technology incorporation would be an example. Work with health systems to scale and integrate the digital health technology and support providers to expand their digital health workflows. Before I go into impact on hemophilia treatment centers, where I think I'll learn probably more from you, to be honest, just want to pause there, Marla, if there were any other questions.
So do you expect the billing practices, not necessarily the reimbursement practices, but the billing practices in terms of coding and what have you, to change in response to the surge in telemedicine?
I think there will be a lot more payments for codes that are related to telehealth that people didn't think about, or even submission of different aspects. So you can submit a blood pressure reading, and if you use something called an F code, as in Frank, and they normally have no payments associated with it. And so most EMRs never built this. And there's multiple of these F codes that health plans now are looking to start paying for. So I think it's important to not always think about, well, this is a code I get paid for. It's really to keep scouring out there of, oh, there's a change now. They're going to add this code and they're going to add that code. It might be $10, $20, but if you get a blood pressure reading all the time, and you can do it through telehealth and it counts as long as it's been recorded by the physician that the patient had an electronic tool and it said the blood pressure reading today is 139/72 or something like that, then that, if that's billed with an F code, can get a payment in addition to the visit. And so those really can start adding up.
And I guess the flip side of that is that if you have a patient who was seen in a telehealth visit, right, and then the outcome of that is you need to come in the office so we can, do whatever, right?
Mm-hmm.
And they're required then to pay 2 office visit copays, right? Whereas if the original, had it been in person in the first place, they could have easily done it on site at that time. Would then the patient be required to submit 2 copays, for example, right? Because there's what's happening on your end, and then there's what's happening on the patient's end, which is so now I had to pay twice for the exact same thing, which could have been done once.
I think right now, at least during the COVID pandemic, for the most part, and I believe across all the US states, contiguous states at least, the telehealth have pretty much no copays. That's all been waived because of the increase and the need to make sure we're providing care, because we know patients are not coming in. And what happens after the pandemic, I think, is there might be more data elements that need to be submitted to say, in support. This is why I did a televisit, and this is why I'm saying they have to come in, or that the televisit provided the care that was needed. It wasn't just, a simple response to a lab result or something like that. There was more entailed, as an example.
Right, and one of the social workers did chime in and say, yeah, many places are waiving all cost shares during the pandemic for telehealth. I can speak from personal experience that they are not doing that in New York City. So in that you have to pay for the copay for telehealth and then pay the copay when you go into the office as well.
So a lot of that is also dependent on the healthcare purchaser. So if the healthcare purchaser is self-funded and it's their money, they do have the capacity to develop their benefit design the way they would like it to be administered. But for all the other rest of the world, at least right now during pandemic, let's try to encourage patients to get seen in whatever way possible. And we want to increase telehealth. So for the most part, there is no out-of-pocket cost for telehealth.
That is an excellent point, and I think I'm glad that you stated that very clearly, which was that, whoever the purchaser is can do it differently. Okay, that was it.
Okay. So this is a slide to kind of indicate, where were the hemophilia treatment centers and to see that they were better positioned than, let's say, primary care to navigate through the COVID. So the circle here is if you look at all patients and everywhere they go, and looking at the provider base, were they not prepared at all to do telehealth or take care of patients, I guess, and I'm saying telehealth just because that's really the main part during the COVID-19, all the way through the circle to here of who was fully prepared. Most HTCs are either associated with hospitals or at least specialist offices, and they can see that for the most part, at least, they have more light green of some sort, and that to indicate they're more prepared than, let's say, primary care offices, where some didn't even have an electronic medical record, believe it or not, in this day and age. So definitely telehealth was not something they were ready for. But expanding that further to define the role of telemedicine in the management of bleeding disorders, HTC's capacity for telemedicine, that's always been kind of their main crux, right? I mean, right from when they were born, it was a patient-centered medical home model. They had 24/7, 365 access to providers, and the providers could be physicians or nurses or social workers. And this has been in existence for many years. But HTCs have rarely ever billed for these services or captured these because there wasn't really a way to do it, right? There was no billing code that they could use, so to speak. And kind of was bundled into this whole I supply the factor drug and that 340B discount is what's helping to provide the service fee. So it was kind of that's when it was born, that's kind of how it got born, right? And then the rural areas, that was a critical component for the HTCs to help take care of the patients. Telemedicine has been linked to reduced hospitalization and adverse outcomes among children with complex chronic conditions such as hemophilia. So we know it works, right, for our patients and having their parents be able to call in, this is what's going on, what do I do, and tell them what dose to give of the factor and make sure they have some extra on hand to do that, but not too much that they're stockpiling versus saying, go to the ER and go get this done. So the growth of technology, telemedicine integrated with this whole growth of technology is reality for further success. And then there's this whole omni-channel that's really, the big buzzword for communication. So traditionally, it's either you see them in person, which we know is really gone away. So after this, gone away meaning because of the pandemic and the fear, not totally gone away, but shifted a lot. But then do you call them telephonically or you send them letters? And many patients just don't respond to that anymore. And they're all wanting electronic, whether it's email, text me, that's high demand. And as this current aging population becomes part of our geriatric Medicare that's lived in a technology-based world, even our elderly are wanting to say, hey, stop calling me and just send me a text or just kind of let me know what that result was or what to do next. Patient interface applications, video conferencing has emerged as a valuable tool. Most EMRs have that integrated into their systems. And so such interventions allow providers to remotely to do a more efficient modality of care versus just doing it, I only do it this way because this is the only way I have to do it. So what's the opportunities associated with telemedicine and HTCs? So as we said, HTCs can take the lead on telemedicine because they've been doing it for so many years, for multiple visits throughout the year for each patient, especially your high risk ones, and especially those supported by large institutions. Primary care and other specialty have been lagging. That's definitely not what they do. Many HTCs had an existing infrastructure to administer the telemedicine interventions, and the COVID-19 pandemic impact on resources and data, I think, are something positive for HTC. So given cause for more HTCs to mobilize their resources, HTC should identify more capability to capture reportable data, respect to the number of patient contacts and telemedicine interventions, because there probably will be more opportunity to bill for all of these as telemedicine codes continue to grow and expand more and more of which population is going to have an impact that's going to be positive to reduce total cost of care, improve quality. Well, let's add that code now, and let's add this code now. So maybe the services that we've been doing through HTCs all these years, where we always say, well, we can't bill for it, there's an opportunity that's really rising, if not already, for a few of the services to be billed. So the challenges associated with the telemedicine, though, would be the infrastructure to execute effectively. So most IHTs have fundamental infrastructure, but not all of them have the bandwidth to execute it effectively. And what I mean by that, you can call patients, but are we tracking everything the same way? Are we able to say if, whether it's Medicare, Medicaid, or private insurers, this is what I did with that telemedicine, this is the result. This is how I did it, this is the result. Like, it should just always be hand in hand, and we aren't doing that on a regular basis because we never billed for it. So we just didn't track it that way. So ongoing reimbursement during COVID, there's liberal reimbursement for telemedicine. Government oversight and change in regulatory policies will likely make it necessary to make it sustained after the pandemic. And so, Marla, that was the point. Like, maybe after pandemic, there might be more co-pays, I'm not sure. So this is what's going to lead to the more stringent data collection and reporting to be able to say, I need to be continuously reimbursed because I'm giving you positive results. So the HTC data collection and reporting is going to become imperative. And right now all payers are looking, what do you do that's unique? What do you bring to the table that's different than the traditional, come see me in my office and I'll have you come in the ER for this. What do you do to take care of our patients in a different way that's improving cost of care and improving quality, and it's meeting the patients where they need to be met at? So the evidence for gap closure, cost reduction, improved patient experience is just becoming huge. So there's something called Medicare 5-star. I don't know if you're aware about that program, but Medicare has all these different quality metrics. They're all way different amounts. And if a health plan gets so much points, they actually get called out as a 4-star or a 4.5 or a 5-star. And each one of those have a different amount of funds that the CMS or Medicare will give back to the health plan. But that dollar that's sent back has to be put right back into the management of Medicare. But that's how you can now give more free food plans. So we have a 14-day food plan offered post-discharge for our Medicare patients with key disease states that we know are causing a lot of negative outcomes, such as congestive heart failure, COPD, etc. Or having free rides so that they can go in to see their doctor. Or what else can we do? They need service in the home. So that's where that money comes back to. Well, 50% of that weight now, actually a little bit over 50% in 2021, is going to be all based off of patient experience. And that's really what you're going to hear more and more from all your health plans, public and private healthcare purchasers, of what are you doing to improve the patient experience? Like, they get questions of, did you like the way your doctor's office looked? Did your doctor respond to you in an appropriate amount of time? What's appropriate? Does a patient want a response in 5 minutes, or is 1 hour okay? They don't define it. Everything is about, what did the patient get their care met at the time and the way that they wanted it met? And with that much weight going to patient experience, and then you have the HCAP scores, right, for the hospitals. There's anything you can think of for HTCs of I'm gathering data, but I am going to come out even further ahead than primary care or other specialists because we already know how to do telemedicine. We've done it for years. But we're going to couple that to show we improved patient experience. If you can come out with that, you will get some unique codes probably built just for you as HTC centers. So summary, initial health costs have changed due to COVID-19 and will continue to change for health systems as more services shift outpatient to digital, sorry. Refinement of pandemic preparedness policies for healthcare and the workplace will be critical. Key lessons and new processes from COVID is really the intensification of telemedicine growth and using population health management tools. COVID-19 will have lasting impact on chronic disease outcomes, and it's going to be pretty negative for 2020 at this point. It's important for healthcare systems to prepare for reopening of clinical activity and the new normal. We've done that at Henry Ford Health System, so I have both a payer and a provider, but not as many patients were coming in. Now we're starting to see more patients coming in, but we now have a lot of staff that was still furloughed because the health systems lost a lot of money during the COVID time because we weren't getting income for any elective surgeries or management of all these other chronic diseases that would bring in, office visits, etc. So it's like this tricky spot where we don't have enough money, but we're starting to get more people. So we got to bring employees back. And so I think it makes it very difficult right now. So with that, I'm going to open it up for questions.
Is there a way, right, to track, who's tracking the F codes? Who's tracking the additional or newer codes that enable adequate reimbursement for telehealth services?
So it's going to actually be based, a lot of that is really going to be based on who your payer mix is and contacting a payer mix to say, we monitor our patients for this on a regular, this is what prevents them from going to the ER. And is there a code that can be developed for that? And that's why I'm being honest right now, HTCs, this is your opportunity to try to figure out how to get paid for those services that you've done for so many years. And now we've been planning through CCSC for many years of what do we do to say we did 50 touch points for this patient, but we billed for none. And so probably can't bill for all 50, but if there's any of those that could be standardized that when we do this, it results in this, you can probably get a code built for that right now.
Can you speak to the challenges regarding helping rural patients get internet access to participate in telemedicine?
So right now, I think that's I removed a slide. There was another slide that was in a deck that I could have put in. And for telemedicine to grow, there's going to be just a huge capacity needed for bandwidth in general, right? I mean, all of a sudden, how many people are at home doing a Teams call? They have their kids on a school virtual call and their system's wigging out, right? And so we know there's that whole issue, but actually just basic, they don't have internet and we need to get that. I think that's a part in the social, that's in society that we got to figure out. I think you'd have to go to your community resources to help with that. I don't know of anything as a health plan that we've been able to find a solution for that directly.
Yeah, I would imagine it's somehow tied up somewhere with education and whatnot, because so many people actually don't have it. What advocacy initiatives do you think we should look for on a telehealth for states? Like, what do you think would benefit a given state with respect to telehealth?
Well, for most state Medicaid plans, they're covering the hemophilic factor. In most states, it's the Medicaid that covers it. So try to put your hat on of, if I had to pay that bill and I needed to decrease that so that I had enough funds in the state to fix my roads or pay for education or whatever else, what are you going to bring to the table to say that when I call these patients, when I do this, I am decreasing your need for that factor because they are bleeding for a prolonged period and unmanaged. And then now I need to give them a high dose for a long time to get it managed again. And you got to just build your case from that perspective of this telehealth call, when it's done with XYZ at results in ABC, and it's got to be standardized. So it can no longer be this very soft, cushy, subjective of, well, they called, so we talked about this, and I think it helped them. It's got to be, you got to have standardized questions. If they called and if it met criteria A, B, C, that means that Y and Z will be met, and that's what I'm going to deliver, and that's what I'm going to prove, and that's why I'm asking for that billing.
Exactly. I think I'm hearing a lot of tracking. You need to, quantify exactly what it is you're doing and when and what benefit it has on patient services.
But not only that, I think it has to be standardized. No state, no private can handle like 50 reasons that they called me, and all 50 of these mean that, drill them down. The 50 are like 3 things, and these 3 things result in this.
Exactly. Can you speak to how best to incentivize patients to follow up regarding documentation that needs signatures and forms, etc., which cannot be done online?
So on the payer side, we actually do try to provide like maybe $10 gift cards or something like that to try to promote patients to come in to get their mammogram, as an example. So unfortunately, money does seem to talk, even if it's as low as $10. If there's something that you have that you think is kind of unique for your population that they would like, if you do this, I won't bug you for the next week. If you do this, then I don't have to keep calling you and asking, do you have this? Do you have this? Sometimes that's a good incentive and patients are okay. Can you do texting? Do you guys have that capability in certain HTCs that you've partnered with your system through? They might have a vendor that has texting. And you can tell your patients, I can put you into a free texting platform if you were to say you would submit these data points all the time. And a lot of our patients just don't want to be called anymore. So they'd like any other way that we can communicate.
Right, because a lot of calls go on a lot of times, and a lot of them are duplicative. Thank you, Vanita, for presenting an excellent talk about the implications and what you can do and what is to come, and managing this whole thing, this whole post-pandemic world, because we'd all like to be in person again sometime soon.
Yeah, thank you.
Bye-bye.
Bye. Have a good day, everybody.